Good afternoon, ladies and gentlemen. We're going to start the shoulder and elbow section of the meeting for the afternoon, and we're going to start with presentations according to the program. There's a slight change in that we're not going to have a midshaft humeral fracture discussion. We're going to rather go towards proximal and distal humeral. We're going to concentrate on that. The program will flow through there. We won't have questions in between the talks, so we'll ask you please to keep your questions until afterwards, and then we'll have a discussion for 45 minutes afterwards. At that stage, if anybody has any cases they'd like to present, they're very welcome to present those cases, and we'll discuss them, but you must put it onto the projector so that the other people can see. Another announcement is that we're going to hold a shoulder and elbow AGM after the SAOA AGM at 3:30. And if there are any members that are here or any members that would like to join the association, you're welcome to stay for that meeting. So we're going to kick off now with Charles Breckon, who's going to talk about clavicle fractures, and then Andrew Barrow will follow with lateral and medial clavicle fractures.
Sorry, I'd just like to announce that at the braai, the people going to the Bush Braai, they meet outside here at the conference center at 5:30, and you must bring your indemnity form, otherwise you won't be allowed to go, and you'll delay everybody else while you're signing your indemnity form. So please bring it filled in already and signed at 5:30 outside the conference center. That's for the Bush Braai.
Thanks, Mr. Chairman, for allowing us to speak on distal clavicle fractures and medial clavicle fractures. As you can see, Andrew and me have swapped talks. Andrew's going to give the midshaft and I'll do the distal and medial. And I'd just like to thank Andrew for his help in getting the paper together. Fred Elman was the first person to classify the clavicle fractures into three aspects, groups 1, 2, and 3. I'm going to briefly discuss the medial side, but go into a lot more depth in the distal clavicle. Just on looking at the clavicle itself, if one just notes how thick the medial part of the shaft is versus the thinner lateral portion, one can appreciate the amount of force that needs to go through the medial side in order to fracture it. So medial fractures of the clavicle account for about 2 to 4% of clavicle fractures, and the common mechanism of injury is a motor vehicle accident or rugby. The associated injuries with medial clavicle fractures is predominantly due to the amount of force it takes to break the medial end of the clavicle. And in the paper by Throckmorton, one can see pulmonary contusions, rib fractures, 73%, and humeral fractures and AC dislocation, 45%, and death as a result of the trauma associated with this injury is in the region of 20%. The classification is, I think the Edinburgh is the simplest. It's either displaced or undisplaced, and it's either intra-articular or extra-articular. The operative outcomes of displaced medial endoclavicle fractures was looked at by Sidhu in 2015, and if you treat medial clavicle non-operatively, the non-union rate for an undisplaced fracture is 6.3%, and for displaced 15%. If you don't treat them, 50% of these patients are symptomatic at 1 year, and if one goes ahead and does an operative repair, you can expect probably about 100% union rate because of it's quite a thick metaphyseal fragment. Surgery, when one's considering surgery for displaced clavicle fractures, because of the vital structures behind the medial aspect, one must stay anteriorly and superiorly to the clavicle, and generally recommended to use unicortical screws on the medial fragment, so that you don't perforate the back towards the carotid. Locking screws medially is preferential, and bicortical screws laterally, and staying away from your brachial plexus and subclavian veins. This is one of our own patients that had a motorcycle accident, and on opening we found that he had a subclavian vein rupture, and luckily we had our vascular surgeon on standby because we were preempting it. The other problem with the medial clavicle fractures is the fascial injuries that you see in the youngsters between 14 and 16, and they're actually just a Salter-Harris 2 fracture, and the problem with them is that 57% are often delayed in diagnosis. One often tries a closed manipulation of these, but invariably they do fall back and sometimes need a transosseous screw tension band through the physis. So the bulk of the talk is going to be on distal clavicle fractures. And when we look at the distal aspect of the clavicle, 15% of all clavicle fractures are on the lateral side. It's much more common in the middle-aged and elderly. They're often unstable, and they're prone to malunion and non-union. The non-operative displaced distal clavicle, one can expect a non-union rate of anything between 22 to 50%. They typically take longer to heal than midshaft, some of them up to 3 months, and symptomatic non-unions do occur in about 14% of patients. Near described, well, when we look at clavicle fractures, we have to think about the deforming forces. And Near described 4 deforming forces, that from the trapezius muscle, the sternocleidomastoid muscle pulling superiorly, the weight of the arm pulling inferiorly, and then the pectoralis and the latissimus dorsi pulling medially. On top of the forces from the muscles, we also have to realize that the fracture fragment is also held to the scapula by the acromioclavicular joint and the suspensory ligaments of the conoid and trapezoid ligament. So that also influences our treatment of these fractures. When we think of the acromioclavicular joint, it's quite a sturdy structure. The superior aspect of the the acromioclavicular joint is 2.5 millimeters, and the trapezial fascia is continuous with the superior aspect of the acromioclavicular joint. Klimkowitz found that the AC joint ligaments stabilize the joint in an antero-posterior direction, and the superior AC ligament obviously is the strongest, thickest portion of it. If one resects the distal end of the clavicle, it can lead to antero-posterior instability if you lose the acromioclavicular ligament. So one should try and attempt to preserve the AC ligament at all costs during the fixation of this fracture. The suspensory ligaments, the trapezoid is predominantly a posterior restraint, and the conoid is predominantly an anterior and superior restraint. So the mechanism of injury of this fracture is usually a simple fall or fall from a height, like this, for example, off a bicycle. It's a direct blow to the lateral end of the shoulder, and we find it commonly in the elderly when they just fall on a simple fall on the tiled floor. This is an example of a 94-year-old patient who fell on the floor and displaced the end of his clavicle. As Andrew, I'm sure, will tell you as well, they repeat offenders, these patients, motorbikers, cyclists, rugby players. This is a patient from the EPIC. He's had 2 distal clavicle fractures, plated twice. He fractured his elbow in 2006, and now in 2015 managed to pull his plate off again, 2015. The classification with regards to distal clavicle fractures, Near described the distal third fracture, and it was later modified by Craig. This helps us understand the anatomy, so I'm going to go through this particular classification as opposed to the Edinburgh one. And the Edinburgh one is quite easy, I think, and most of us will agree that if the fracture is non-displaced, we'll treat it conservatively. If it's displaced, we'll treat it operatively. But this is just a brief example of the Edinburgh classification, again, intra-articular or extra-articular, and displaced or non-displaced. The Near's classification is a lot more complicated, but it helps us go through the anatomy, and I'll just go through each one of these, types 1 to type 6, quickly, and give you an idea of how it pertains to surgery. So the Near type 1 is a fracture lateral to the coracoclavicular ligaments. It's a stable fracture, and we can treat it non-operatively or with late excision of the distal segment, and it has a high union rate. The type 2s are displaced fractures, and the displaced fractures are either medial to the coracoclavicular ligaments. This is unstable with a high rate of non-union, and it is preferable to operate on these. The Near type 2B is the conoid ligament is torn, but the trapezoid ligament is intact. They unstable, also have a high rate of non-union and malunion, and one should operate on those. The type 3 is an intra-articular fracture right at the end of the bone. It's a stable fracture. Non-operative treatment is fine with late distal clavicle excision if it's painful. They have a risk of post-traumatic arthritis, or they can develop osteolysis like this case here on the end. The Near type 4 is a physeal injury, which is a Salter-Harris 2 fracture. Comes through a periosteal sleeve. The distal epiphysis continues to be cartilaginous in up to the mid-20s. It can be mistaken for an AC dislocation, and the oldest patient in literature with a physeal injury was 21 years of age, and surgery is really just to close the periosteal tube, and then you can do a figure of 8 through the physis, and if you felt it was still unstable, pass a PDS band around it. The type 5 is a fragment that's left behind with the conoid and trapezoid ligament attached to it, and this is also unstable, and again, open reduction internal fixation is better. We felt that maybe there should be a type 6 and a 7. We've seen a distal end of clavicle fracture with dislocation of the AC joint. And again, this is an unstable injury. And for this particular one, we used a hook plate, but you could use a coracoid loop and a tension band of the fracture. And the type 7, which we think is possibly a type 7, is we get a distal end of clavicle fracture plus a coracoid fracture. And in this particular case, used a double plate technique just to stabilize a small fragment and then do a hook plate. But again, there's a number of options available. So what does the literature tell us about fixation of the displaced fractures? There's numerous methods to deal with these fractures, ranging from K-wires right through to dorsal plate to tightrope. Frankel and his group compared hook plate and dorsal lock plates. They had 38 patients with a union rate of 95%. Their hook plate had a slightly lower AS score compared to 77. They found if you treated these fractures acutely, they did better. Their complication was much higher in the hook plate, 23% versus 6% of lock plate. The paper recommended rather treat them acutely, and they preferred a dorsal plate plus a corococlavicular suture. A very good paper coming out from Cape Town, Steve Roach and his group. They looked at 19 patients with an angular superior locking plate and cerclage suturing of just the fragments, not going around the corococlavicular or going around the coracoid. And they had a union rate of 100%, and their aim was not to remove the implant. Their conclusion is, irrespective of the degree of comminution, just cerclaging the fracture fragments and holding it with the angular screws gave a satisfactory bone purchase. And Steve tells me he's added another 30 to this, and they're also doing just as well. So I think the Krudder paper highlights the fact that it's a comminuted fragment, and one doesn't appreciate how comminuted these fragments are, and a CT scan does show us how badly it can be. When one looks just treating them with a hook plate, the type 2's good in his paper, looked at 36 patients. Mean time to union was 3 months, 95% union rate, and 92% of the patients needed a plate removal. And 2 of the patients fractured through the medial end where the screw inserted on the hook plate. Robinson, who's quite famous for his classification, treated some of these patients that were less than 60 years of age, just with a double corococlavicular ender button, and they had a very good union rate, and 1 patient had post-traumatic stiffness. The critical thing in his paper was you have to reduce the fracture if you want to get a good result. Offa Levy from the United Kingdom looked at 12 patients, and all they did was a simple PDS band and got a 100% union rate. We're a bit concerned. I don't think one can sort of guarantee that just with a simple PDS, but he said he did get that. And then from Cairo, Soliman looked at 14 patients, and they talk about an under the coracoid around the clavicle suture, and 13 of the 14 went on to union by 18 weeks. So the complications we've seen in our own practice with a hook plate, on removal of the hook plate, it looked reasonable, but went on to osteolysis at 6 years post-operatively. We've had a non-union and a mild chromal erosion from a hook plate. Once the plate came off, went on and developed a non-union 2 years post-operatively, but he was asymptomatic with no pain. The complications of the lock plate, we've had a screw back out, and this case was referred to us as sort of inadequately compressed. We exchanged this with a bone graft. He's starting to unite, but I've asked him to return in 6 months because it's a year down the line, but it still seems to be struggling to unite. The other complication is this patient also referred to us where the plate had been pulled off. We regrafted it and put a CC loop around this patient, and it's gone on to unite quite successfully by 6 months. So in conclusion, your type 1s and 3s can be treated conservatively, but the 3 can lead to arthritis and osteolysis. And the take-home message for the type 2s, the 2As and 2Bs, I think Stephen Roach is right with his group, a dorsal plate plus a cerclage suture just around the fracture fragment. You can either use one suture or two sutures, one around the plate, one around the fracture. And if you felt it was still query unstable, maybe you could add a coracoclavicular augment. For the very tiny little fragments, not on this particular thing, but if you had a very small fragment, you could try a tightrope, or you could do just a tension band suture of the little fragment on the end. I think the take-home for us is we would tend to try and avoid a hook plate unless there was an associated coracoid fracture, because it's in the literature and we've also seen it. We've had a much higher complication rate with it. Thanks for your attention.
Thank you, Charles.